So I wanted to hand this over to Dan Benedetti, who is an assistant professor of pediatrics in the Division of Pediatric Hematology Oncology at Vanderbilt. And he leads efforts in pediatric oncology to manage our patients with inherited forms of cancer alongside other colleagues. So we're really lucky to have him at our institution. And he's also got robust expertise in bioethics, including complex decision-making and conflicts over treatment decisions for pediatric cancer patients, which again intersects nicely with inherited cancer care in these patients frequently. So with that, I will turn it over to Dan to tell you a little bit more about pediatric inherited cancers.
Thank you for that kind introduction and for having me, and hello to everyone who's attending. All right. So I'm going to talk a little bit about sort of as a pediatric oncologist, because that's really where my training starts. I'm not a geneticist. And think about how many in our field have sort of approached cancer predisposition historically, how really this part of our practice has dramatically changed in the era of next generation sequencing, and then talk a little bit about what this looks like in terms of patients coming in and out of the pediatric oncology clinic, either from a cancer diagnosis or a cancer predisposition diagnosis. So the sort of historical and what I was sort of taught as a medical student and resident was, yes, I should be taking a good thorough family history, and that if I get a history of patients with a family with a single cancer running through multiple family members, every woman in the family has breast cancer, then I should be thinking about the possibility of cancer predisposition, or a family that has lots of cancer throughout multiple generations, potentially of different kinds, and that really, as a pediatrician, that would trigger me to refer them to a geneticist, or potentially an oncologist, depending on the situation. But there's some problems with this sort of approach. One, time is an issue. There really just isn't enough time, and many of us, it becomes a low priority for pediatricians and even for pediatric oncologists to really spend all the time going through a thorough pedigree, making sure the family has all the information on their loved ones and family members to get that. The other is knowledge gaps. It takes a lot of specialized knowledge and training to really do the right degree of family history. And then the changing landscape of actually identifying. You may say, I know that breast cancer, if it's inherited throughout, there's a related gene for that. But when we're identifying new tumors all the time that potentially go along with various cancer predisposition syndromes, that's a lot of knowledge that most pediatric oncologists may not have, let alone the general pediatricians who may be seeing some of these patients. And then access to cancer geneticists. And so that's certainly an area where, for example, the TIPS study may be of benefit if we can figure out making sure when people identify patients who have this, they have access to someone with the expertise to provide the counseling, identify the right potential germline genes to test, et cetera. The other way these patients have historically been recognized, the pediatrician or oncologist suspects that they have a syndrome. They have some sort of congenital anomalies, and they say, they should see a geneticist to be evaluated for a cause of this. And then they're diagnosed with some syndrome, for example, Beckwith-Wiedemann's, and therefore we recognize they're at risk for pediatric cancers and referred for screening. When I became an oncologist, I oftentimes get asked this other more important question: why did my child get cancer? And I haven't been doing this that long, but when I was very early on being taught, the answer was almost always, we don't know, but we know it's nothing you did or didn't do to cause this. And I've had to adapt my answer and approach to this in the last 5 years, as there have been a ton of publications that have sort of shifted our understanding of the hereditary nature of many pediatric cancers. So with next generation sequencing, there have been many studies. This is one out of Dana-Farber, where they did somatic testing of patients with relapsed solid tumors, and identified that many of them through secondary findings really did have a suggestion of germline findings. This is one of the seminal papers in the New England Journal from 2015, identifying germline mutations in predisposition genes. Memorial Sloan Kettering has really, and others have gone to testing all patients. This is pediatric solid tumor patients for germline findings. And then St. Jude has a study where they really look to sequence every pediatric cancer patient. And so this is a growing part both of what some centers are doing, but has led to an increased recognition that many of our children with cancers really do have genetic predisposition. How many? It's certainly, as I said, more common than we previously thought. The studies sort of range somewhere in the 10 to 15% from those sort of pan-cancer cohort studies, but this number will probably continue to increase. This is how it was done on that original study I showed, where they were really looking for identification of targeted therapeutic options, but in doing so identified that there was a subset that really had possible cancer predisposition syndromes as well. One of the more recent efforts or publications, there have been a number of them, really looking at individual pediatric cancer cohorts. And so we've long identified that certain tumors, Sertoli Leydig cell tumors, for example, and Dicer1 mutations, or choroid plexus carcinoma, and low hypodiploid ALL with TP53 mutations, we sort of recognize that there are sort of these sentinel cancers that should trigger us to think about a germline predisposition. And in recent years, there have been looks at specific diagnoses. So in the sarcoma world, this paper from 2020 looking at osteosarcoma and the frequency of pathogenic germline variants. And then this year, two papers looking at rhabdomyosarcoma, one in children and young adults, and the other from the Children's Oncology Group at their cohort of pediatric rhabdo patients, to identify and recognize that it's a much higher percentage than we historically thought. In the embryonal tumor world, which is where I mostly practice clinically, we've long known that there were many syndromes associated with Wilms tumor. Most of them have congenital anomalies of the genitourinary tract system. But well, this appeared funny. This was a paper from a couple years ago where this group identified that actually almost 15% of children with hepatoblastoma have germline mutations in APC, and so have familial adenomatous polyposis. And then this year at the AACR meeting, virtual meeting, this group published or had an abstract looking at neuroblastoma patients and identifying that while historically we had said only 1 to 2% had this sort of hereditary neuroblastoma, they were able to identify closer to 15% who had pathogenic mutations or likely pathogenic mutations in cancer predisposition genes. So this has really shifted sort of our recognition that it's probably far more common than we used to think. So now in 2021, when I see patients, really, some patients are referred to me because of a family history. They have a family history of neuroblastoma. And ideally, I think these patients should really be seen by a geneticist or genetic counselor with expertise in hereditary cancer, though we get them into our clinic and may talk with them and help educate them a little bit, make sure there's no sort of urgent testing that would need to be done to screen, and then refer them to a geneticist. But these do come through pediatric oncologists still. The biggest area is really once we identify a child who has cancer. And so, my patients with childhood cancer in our clinic or in our practice, one of these other features really should trigger our thinking about the possibility of hereditary cancer, either their own prior history of cancer or a family history. And so this is where we have to have sort of renewed education and emphasis and make sure we're really taking appropriate family histories for these patients. Tumor types. So as I just alluded to, there are certain tumors that really should trigger this recognition in our patients, and that list is growing. And I'll give some examples of that in a minute. expansion of tumor sequencing is happening. At this point, it's almost standard of care for relapsed or refractory tumors and cancers to have next generation sequencing. Some centers are doing this upfront for all cancers. Those tend to be the very large and in a research setting. But that is a growing part of our field. And then there have historically been this idea that patients who have excessive toxicity from their cancer treatment should be referred. I put a question mark here because when this has come up in our practice, we've had discussions with the geneticists and ourselves that we're not really sure what, beyond a few syndromes, how comprehensive that testing should be or what that looks like. And so that's probably an area where we need a little bit of attention on a research basis to try and understand what does it mean if they have, quote, excessive toxicity. So this is now 5 years old, but this was a tool that was published in the European Journal of Medical Genetics, sort of to hopefully help pediatric oncologists recognize genetic predispositions. And so they suggested that if your patient fulfills one or more of these criteria, she may benefit from referral to a clinical geneticist. So these are pediatric cancer patients who have a family history of cancer, who have a personal history with any of these, and I'll show the table in a minute: tumors in childhood, a child with 2 malignancies with at least one of them of onset under 18, a child with cancer and congenital anomalies or symptoms, and then, as I said, this child with excessive treatment toxicity, though it's not really defined beyond that. This was the original list of tumors that they proposed, which include ones like PPB, which we recognize with Dicer1 germline mutations, adrenocortical carcinoma for Lee-Fraumeni or Beckwith-Wiedemann, and there's sort of lists of tumors, though I'll say this list has expanded significantly since 2016. More recently, a group from McGill developed an app and a algorithm that they call MEPOG, or the McGill Interactive Pediatric Oncogenetic Guidelines, that sort of expands upon that. And what they do is they actually take by tumor algorithms that they've built into this app. And the goal is to, again, identify children at increased risk of likelihood of having a cancer predisposition syndrome. And so when you go to the app or the website, they have algorithms. So you can put in neuroblastoma, and then it'll have a series of yes or no questions. And based on your responses, it will generate a recommendation for or against a genetic evaluation. And so they published this originally in 2017. They've subsequently published a number of papers that look at how well this tool works to capture both patients with predisposition syndromes and then patients who are at risk, who have gone on to develop secondary malignant neoplasms. So here we've sort of taken in the last year or two all of this growth of publications and attention in this field to sort of say, all right, how can we make sure we're not missing patients that really warrant referrals to for genetic evaluation? And so we adapted that sort of initial list, took the AACR series of publications from 2017 and have come up with our sort of own list for now as a starting point to try and say, how can we make sure that we're recognizing just from a purely this is the tumor they have, they should have some sort of genetic counseling and potentially germline testing. And so this we've just presented recently at our own division meeting, and I'm trying to make sure we're recognizing which patients should be referred. So the last part of what this practice looks like is what Tua alluded to, which is actually doing some of the cancer surveillance. And so once we sort of confirm that a child has a cancer predisposition syndrome, we have to consider whether for that syndrome predisposition or surveillance is appropriate. At this point, the considerations really are consensus statements and guidelines. This is the biggest area of the field in the literature. So that AACR series from 2017 and other papers that say, based on the existing data, here is what we recommend. But those are largely just consensus guidelines. Data in terms of what modality of surveillance, when to start surveillance, how often to do those surveillance studies, and even who really needs it are scarce. And so then the other consideration is really family preferences. And this is where I do a lot of shared decision-making with families, both to provide them education about the likelihood we're going to find something, the risks of what we're proposing, whether it be a sedated MRI or a non-invasive ultrasound, and the downsides of that, and try and factor that in to come up with a plan that makes sense for my patients. Surveillance here, where I'm doing a large amount of this for our pediatric cancer patients, but depending on the institution, this may be done by geneticists, and some patients may have their pediatricians doing and coordinating some of these scans. And so it really depends on both where you are geographically, the expertise in your area, but this is certainly a growing part of this. And I trained at a center that had a very formal cancer predisposition syndrome clinic with an oncologist who was also genetics trained. Here, I've taken this on largely, though Deborah Friedman does some of it as well. And in other places, these are sort of growing clinics that need to happen as we as a whole field of pediatric oncology recognize the need for this to be a part of our practice. The last thing I just want to point out about that is with these consensus statements and where they've come from. So the 2016 AACR workshop, they came up with their recommendations with the idea that they wanted to be uniform for each tumor type. So if you had a predisposition to Wilms tumor, whether you had Beckwith-Wiedemann or another syndrome, they wanted it to be the same to minimize confusion. They were going to offer screening in cases where the syndrome had a 1% or greater risk of that type of tumor, and where early detection is minimally invasive and significantly improves outcomes. 3 years later, at the Children's Oncology Group, Cancer Predisposition Working Group, they came up with a slightly different definition or a guideline for when to recommend screening. They said when the risk of the cancer was greater than 5% in the pediatric age group, or where the risk was between 1 and 5% if screening was non-invasive, cheap, and where there was a poor prognosis where early diagnosis may improve outcomes. And this is just the sort of US sort of approach. In Europe, they have sort of different thresholds, and I've seen some of their work describe really above 5% risk as being appropriate for certain modes of surveillance. And so this is just to say that these are not necessarily data-driven. The last thing I want to point out is one of the areas where we actually do have some data involve Beckwith-Wiedemann and Wilms screening, where we have a number of papers, one of which pointed out that screening really does detect lower stage tumors. So this is now 20 years old or so, but in patients with Beckwith who went on to develop Wilms tumor, those who had been getting ultrasound screening versus those where the tumor was identified and hadn't been getting screening, they identified tumors at a lower stage if they were having screening done. My kidney overlapped here on my view at least, and that the interval of screening matters too. And that if you were doing screening at an interval of less than 4 months, so ultrasounds every 3 or 4 months, none of those patients had stages 3 or 4 tumors identified, whereas patients who were getting screening done at greater than 4-month interval, almost 40% of them, when they had tumors, they had already been a stage 3 or 4 at the time of detecting it. And so this is one narrow area, at least, where we actually have some data that say that screening matters and the interval of screening matters. But in the majority of what we do in screening these patients, we don't have data that say what the right mode, timing, intervals, et cetera, are for doing the surveillance. So that's really what I was hoping to cover today, is what sort of my practice and what a lot of the pediatric oncology world is. I'm happy to field any questions or just pass it along back for ongoing discussion in cases.